I am very, very happy to introduce Katherine Hoerster. Dr. Herster is an investigator at the VA Puget Sound Center of Innovation for Veteran-Centered and Value-Driven Care and associate professor in our department. She also provides clinical care on the VA PTSD clinical team. She received her PhD in clinical psychology from the SDSU UCSD Joint Doctoral Program, where she also received her master's degree in public health. Her research examines improving healthy behaviors, especially among veterans with PTSD, and she has published over 60 peer-reviewed papers related to these topics. She recently completed a VA Health Services Research and Development Funded Career Development Award that's focused on developing and piloting Move Up, a weight loss program she developed to address obesity in veterans with PTSD. She's now studying that intervention in a VA merit-funded trial, and she will describe that work as well as the broad issue of weight and weight management. So welcome, Dr. Herster. Take it away.
Thank you so much. It's lovely to be with you all today. And I am excited to talk with you about how we can promote population health equity through behavioral weight management care and primary care. So the objectives for the presentation today are I will present some epidemiological data about the prevalence of higher body mass index and also determinants of higher body mass index, and with a special emphasis on how social determinants of health and psychiatric conditions and the intersections of the two influence higher body mass index. And then I will talk about how weight management is delivered in primary care. I'm emphasizing behavioral approaches. I'm a psychologist, as was just mentioned, and so I'm going to emphasize behavioral approaches, but I will talk about alternatives to or augmentative approaches to behavioral ones. And then I'll close by talking about the work I've done to address overweight and obesity among veterans with PTSD. So I will, in general, work to avoid stigmatizing language in the presentation. Larger bodies, people with larger bodies are unfairly treated in our society. I'm sure you're all aware of that. And that is harmful, both in terms of delivering effective care and the impact of that on individuals. And there's increasing emphasis in care that's focused on and research that's focused on weight to use more body positive language. And I will absolutely try to do that in this presentation. What I will do overall is talk about higher body mass index or talk about body mass index cutoffs. I'll also try to use person first language. I probably will slip up because, as with most of us, I've internalized some of the common medical language that we use around this topic. And but know that it's my intention to avoid stigmatizing language. And I also, in accordance with that, am going to present with an equity and patient-centered lens. I think it's really, really critically important for us to think about, just as in the 4 M's, what do individuals want? What do they care most about? And how can we as healthcare providers support them in doing that? So real patient-centeredness and thinking about how to address disparities in this area. I want to acknowledge that my expertise is really, as I mentioned, in the behavioral realm. And so I'm going to focus on that in my presentation. And I also bring to this work, a unique lived experience. And for example, I live in a straight-sized body, as some people would call it. So I am not currently working on my weight. So, I think it's really important when doing this kind of work to acknowledge where your sort of positionality is in this line of work. And so I just want to acknowledge that up front. Oftentimes providers bring to a behavioral weight management their own biases and so forth. And so acknowledging that, I think, is a really important part of this. Why I pursued this work now over a decade ago is because I see an opportunity to help people live functional, joyful lives through working on activity and healthy eating. And healthcare systems really prioritize delivering those interventions for people with higher body mass index. And so that is what I bring to this, is that I see behavioral weight management as a place that we as healthcare providers can meet individuals' goals and help them live full, meaningful lives. So that's why, I focus on behavioral weight management in my work. From an epidemiological perspective, why is this an important public health topic? We know that 42% of US adults have higher body mass index. So in this case, that's a BMI of at least 30. So that corresponds to a designation of obesity. And the prevalence, there are really substantial disparities in the prevalence of BMI of at least 30. So individuals who have a Black identity or who are Hispanic have a higher body mass index than non-Hispanic whites. And we really observe similar rates and disparities in the VA as well, in some recent epidemiological data that was published there. So why does this matter? That higher BMI is so prevalent? Well, it's associated with cardiovascular and metabolic risk. And as we've now recently learned in the last couple of years, certainly the most pressing public health matter we've all faced and continue to face is that, at least in some research, that higher BMI is associated with severe COVID and bad outcomes from COVID. And probably, and certainly those are all age-related issues. But I think particularly relevant to this group is that having a higher BMI is associated with reduced quality of life, of functioning. And of course, that is, again, why I think most people come to healthcare systems for support with weight loss. This is an issue of relevance to older adults. So these are CDC data from not too long ago that show that in all adults, so this set of bars on the left side there, that while BMI of at least 30 is most prevalent among 40 to 59-year-olds, the second highest percentages are those 60 and over. And you can see that really those differences aren't even observed among women. So this is certainly an issue that patients will be bringing to the healthcare system who are older adults, and that we need to have good interventions to support them with. In addition to, and I should say that for most individuals up to a certain point in the aging trajectory, most individuals have a trajectory of increasing weight over the course of their adulthood. And I'm part of a study that's examining those trajectories in the VA, and we've seen that in the VA as well. Accordingly, that same trend is observed in terms of rates of high BMI in the US. So what we're seeing is that over time, rates of BMI have increased, and this really impressive study that came out a few years ago, that by 2030, nearly half of adults are expected to have a BMI of at least 30. So and there are a number of states that are expected to have greater than 50% of their population with a BMI of at least 30. And in no state will there be, is it expected there will be less than 35% in that state. What's called severe obesity, so BMI of at least 35, is likely to become the most common BMI category among women, non-Hispanic Black adults, and low-income adults. So much like the prevalence and disparities that we observe now, it is expected that, a very high BMI will not be evenly distributed in our population. And, this is not, though, a foregone conclusion, that there are efforts that we can put into place now to, flatten this curve and prevent this increasing BMI prevalence over time. So what is it that contributes to high BMI? This is a model that a colleague of mine, Jessica Breland, and I adapted from the NIH ADOPT model. So NIH has developed, they produced a series of papers that outlined the contributors to outcomes in behavioral weight management or weight management interventions. And it really applies, a lot of the determinants are really relevant to weight and weight gain and so forth as well. And so we've adapted that model to, and this is a really simplified version from what the NIH version presents. And but these are the big buckets of contributors. So certainly the one that, we are all probably quite aware of is the behavioral bucket here on the right, that, we're told that eating and physical activity are the sort of main contributors to one's weight. We have increasing understanding and emphasis on the fact that sleep also contributes, both directly and then in its because of its effect on those health behaviors of eating and physical activity. And then certainly health service use, which, the use of interventions by the health system can either increase or decrease one's weight. But what's often not emphasized really all that quite as much. I mean, certainly the psychosocial realm is emphasized in things like understanding that motivation is a contributor to behaviors. But what's not often emphasized enough is this environmental context that has an influence on one's psychosocial, well-being and ultimately their behavior, both through psychosocial factors as well as directly. So just as an example, that, and I've highlighted the concept of social determinants of health, thinking back that we know that there are really striking disparities in prevalence of high BMI between, say, white and Black individuals. Well, the reason for those disparities is not biological, but rather we know that that systemic racism contributes to health behaviors, psychosocial functioning, and directly to weight. So just as an example, if one, so segregation at the community level has been found to be associated with BMI. So people living in low resourced neighborhoods have higher body mass indices. And those with, better access to resources, to higher quality schools, to grocery stores, walkability, and so forth, have lower body mass index. And it's pretty intuitive when you think about it, that those things would really affect someone's behaviors and their weight. And the other piece of this that we probably all can think of examples of how this shows up in our lives is the social environment. So how those in our home relate to and promote either healthy or unhealthy foods, for example, or if you have a partner who, asks you to get out for a walk after dinner or something like that, that can really make a difference in the behaviors that you adopt and ultimately your weight. I also want to just acknowledge for a moment that not only do, the social determinants of health sort of directly impact these behaviors and health outcomes, but they interact with one another. And this is a figure from a paper that I collaborated on with some colleagues about the climate and obesity syndemic that is increasingly understood to be this sort of confluence of factors that potentiate one another. And I'll just say, as to simplify things a little bit with this, that many of the drivers at the systems level of high BMI also are driving climate change. So for example, our country's food policies and how certain foods are subsidized, or land use policies, that those influence access to healthy foods and food insecurity, which influences body size. And those land use practices also influence climate change. And we know that both of the climate change and high BMI tend to be more impacted for people with low socioeconomic status and people of color. And then they synergistically influence one another. We now know too that climate change is influencing the emergence of zoonotic diseases, and that COVID was one of those. And again, that obesity and food insecurity and so forth are all sort of synergistically increasing risk for COVID. And the big point that I want to emphasize with this is that we have certain populations that are vulnerable to all of these influences, and they often are going to be the people presenting for care, for help with weight management. And I think it's really important for us as providers to help develop some patience and compassion for themselves as they're working within a system that of our society that may not be so conducive to making significant changes in one's lifestyle, and to be patient as they're pursuing those changes. The other thing that I think is really important for us all to remember is that it's really important to provide healthcare to individuals around behavioral weight management or weight management services, but that it's equally important to work with our research and with policy, evidence-informed policy to impact these systems level drivers of these challenges for folks. So on the sort of other end of the spectrum from the environmental context, which we know has such an impact, is the biological level. And because my work has mostly focused on the environmental context and psychosocial factors, I'm not going to cover the biological piece as significantly during this talk, but it's absolutely important. And yet another reason that it's important to help people have patience with themselves as they're working on lifestyle change. Just an example of a figure that displays the metabolic adaptation that occurs in the context of weight loss. So this is this complex system that responds essentially in order to bring someone back to homeostasis if they've had weight loss. And so the body, adapts and adjusts energy expenditure and hunger signaling and so forth. And, I think that, a patient doesn't necessarily need to have all of this explained to them when they're pursuing weight loss, but I think it's important to emphasize to people what is and what isn't within their control. And, what in this process of pursuing change in their weight or their lifestyle is bringing them joy, is improving their quality of life, because a lot of this is outside of their control. Although one other piece that is important with this is that certainly more gradual, realistic change is also really important, so that sort of like an extreme adaptation isn't triggered. But probably the most important thing is for people to just be kind with themselves as they're doing this work. So speaking of that, I will emphasize particularly towards the end of the talk, this bucket of influences on weight, the affect and stress. So how our emotional experiences and stress affect weight, and what the efforts that we're taking in our work at the VA to improve coping and so forth in the context of weight loss, to improve both health behaviors and also mental health functioning as well. So back to why focus on weight. When you, particularly using a sort of medical intervention model, when you consider all of those many influences on a person's body size. Well, this is what keeps me coming back to doing this work, which is that many people want to lose weight and many don't. And I think that that should be really honored and not pushed. But for those who do want to lose weight or who are open to it, for whatever reason, that we want to be able to support them with interventions that are helpful and healthy and realistic. Because otherwise people turn to, commercial approaches or things that are maybe too extreme or potentially harmful. And so it's really important that our healthcare systems provide evidence-based interventions that have been tested for safety and so forth. One thing that has come up with colleagues who are concerned about this and whether it's even a good idea, given how stigmatizing or potentially outside of people's control weight is, well, what are their motivations? Is it because of, unfair, expectations in our society about appearance? I never try to convince somebody about, why they should or shouldn't want to lose weight. If they come to seek care because they want to lose weight for appearance reasons or have a desire to fit into clothes they used to wear, or pressure from loved ones, I am not in the business of trying to convince people of their motivations. Certainly I know it can improve one's health or functioning, but wherever it is that they're coming to doing this work, I think we can meet them where they're at and provide, like I said, supportive, whole health focused interventions. Just to, show some numbers that back up how many people it is that are trying to lose weight. This is a phenomenon that's really increased over time and perhaps corresponding to the increase in prevalence and high BMI over time. But you can see that particularly among women, this is a concern and increasingly so, and particularly among people with higher BMI. So 97% of adults with BMI of at least 30 have ever attempted a diet, and many have attempted over 20 diets. And yet again, I think really reminding us of how important it is to provide high quality education and information about so that people don't select really extreme diets that aren't going to be successful in the long run. So what are those effective treatments that are recommended by our experts? And, with a behavioral weight management approach is often recommended as the first line treatment, or at least a necessary component by most in most settings. So the US Preventive Services Task Force, for example, their recommendation is stratified by BMI category. And so you can see that they use cardiometabolic risk factors to stratify within those who have BMI of under 30. But for those with a BMI of at least 30, regardless of cardiometabolic risk, their recommendations at this time are to provide or refer intensive behavioral counseling. So you might know about the diabetes prevention program is just one example of that. It's one of the more effective and well-tested behavioral weight management interventions. Its initial form was quite intensive, and many other less intensive programs have shown benefit as well. Oh, this is my alarm, sorry, to take the bus, which I won't be doing today, excuse me. In the VA, so many of the lighter touch interventions are still pretty intensive. So in the VA, we have the MOVE program, which is a 16-week intervention that I'll describe in a moment. But there are many also pragmatic diabetes prevention programs that have been integrated into the community. The key components are encouraging, a balanced diet that's guideline concordant. So, really heavy on the fruits and vegetables and fiber-rich foods, and meeting physical activity guidelines, both for strength and cardio exercise, with a target of at least 5% weight loss, because that's what is associated with cardiovascular and metabolic risk reduction. In the VA, as I'm, again, being at the VA, I'm really focused on our weight management program, which is called MOVE, and it is a nationally disseminated weight management program, which is really pretty remarkable. It is probably the most accessible behavioral weight management program in the country because we have a national healthcare system. It's free, and that even, regardless of ability to pay, there's never a copay associated with attendance. And it's at essentially all of the healthcare facilities in the VA, whether it's a major medical center or, a community-based outpatient clinic, and even some of the smaller outposts as well. It is a 16-week evidence-based, primarily delivered in a group format, and it's within primary care, delivered within primary care, usually within that structure. And it's effective in accordance with sort of what other such programs like, routine care programs are demonstrated to be. So around nearly a third of those who participate intensively will lose that clinically meaningful amount of weight. And it is that level of participation is also associated with reduced cardiovascular and metabolic risk. And when I say participate intensively in the VA, that's typically defined as attending at least 8 sessions in a series of several months. Really important to note is that it is not equally effective for all people, all veterans. So some work that I conducted nationally in the VA showed that veterans with PTSD and also Black veterans are far less likely to lose clinically meaningful weight. And in both cases, colleagues and I are doing work to address those disparities and improve outcomes for veterans with PTSD and Black veterans. And, again, I just want to highlight this model about determinants of weight loss that it makes sense given what we know about the influence of social determinants of health that people with PTSD and Black veterans would have more barriers to weight loss because of the systemic nature of, how if your access to food, for example, is impeded, it kind of doesn't matter how motivated you are to lose weight. It's going to affect your ability to participate fully and get the benefits of the weight management program. So I described that, people who participate intensively have pretty impressive outcomes in the MOVE program. A really big problem, though, is that only 2 to 12% in a systematic review that was conducted by Matt Maciejewski, only 2 to 12% actually participate at that level. So many are referred, the vast majority of eligible participants are screened and at least recommended to participate at the national level, but then, sort of down from there, when you get to intensive participation, that is a sufficient dose. Very few receive that level. And that's due to a variety of barriers, travel to care, even in, in the VA, the patient population is really, really dispersed, and living further away from their VA medical center is a barrier to participation, as well as, it's a group-based intervention. So it's offered at a specific time. And if that time doesn't work for you, then there's not many alternatives, although the program has increasingly turned to telehealth options to address that gap. So I did want to take a moment to talk about that, because I think the VA has done a particularly impressive job of trying to overcome at least those travel and distance related barriers for weight management care. So even prior to the pandemic, there was a program called Telemove, which provided individual nurse care manager delivered weight management care over the phone. And then we also have in the VA a really robust telemedicine program, and including providing tablets and so forth to veterans who either don't have a device or don't have access to the internet, because those tablets are cellular enabled. So I wanted to highlight a paper that we have coming out that showed, just to underscore how great the VA has done on this. So prior to March 2020, which we all know was the start of the pandemic, 20 to 30% of MOVE was delivered by telehealth. So still pretty substantial. But by April 2020, so within a month, they were able to pivot to 90% of that care being delivered via telehealth. So we were really prepared to make that transition rapidly. And the reason that that program really needed to be delivered by telehealth is that if it's all group-based, most VAs really stopped delivering group-based care for the safety of the veterans involved. Our VA in Seattle still hasn't resumed group-based care, for example. And then the issue, though, is that even with that impressive pivot to telemedicine, the participation in the MOVE program was still 20 to 40% lower, depending on the time frame, than it was prior to the pandemic. So we were faced with even probably a bigger gap in or a bigger unmet need for weight management care as we conclude this acute phase of the pandemic. So the other model of care that holds some promise is asynchronous delivery. So self-delivered formats, whether online or even DVD-based. I just concluded a trial that did a DVD or web-based behavioral weight management program modeled after the DPP that holds some promise. Basically, I think the most important thing to say here is that certainly the pie in the sky, intensive in-person or, virtual delivered group-based care is, optimal, but many people are not going to be able to participate in that. So we need a patient-centered menu of options, including things that are more self-delivered so that people can do them in their own time and at their convenience. So I started out the talk by talking about behavioral weight management and stigma, and I want to highlight that a little bit now in terms of how we think about approaching behavioral weight management in a way that doesn't perpetuate weight bias. And this is really important because weight bias is harmful. It's psychologically harmful. It harms people's health, and it certainly can make a weight management intervention less effective for somebody. And it's the case that half of adults with a BMI of at least 30, in this study at least, have very high weight bias internalization. So internalization of the stereotypes and biases that we have in our society. Just as an example of some of the items that on this measure, that's probably the most common measure of internalized bias. Number 5, whenever I think a lot about my weight, I feel depressed. Number 8, because of my weight, I don't deserve having a lot of friends and fun. These are really painful beliefs that people carry around about themselves and their bodies. And maybe paradoxically, but I think it's possible. I think behavioral weight management interventions are a really important place to actually support people to develop more positive beliefs and attitudes about their bodies. So how do we do that? I think one of the first things we need to do, I'm a researcher, and I think that we need to better understand how weight bias changes or doesn't, whether it improves or worsens during the course of a behavioral weight management intervention. So it needs to be measured in our trials, and it's rarely done. And does that differential, is that differential based on whether someone loses weight or not? But I think that, many of the weight management programs, and certainly the sort of gold standard approach that is emphasized with the MOVE program is, people come to the program to lose weight because they want to, or their doctor wants them to, or their loved one wants them to. But once they're in the door, the real emphasis should be on the things that are within that person's control that may or may not influence their weight. So physical activity, as much as possible, physical activity that brings them joy or fun or is functional. And likewise, guideline concordant food and beverage consumption. So, and similarly, facilitating conversations that can help them pursue, joyful and meaningful interactions with food, regardless of whether ultimately they see that change in the number on the scale. Likewise, having people step back and ask themselves what they care most about in their lives, and setting realistic goals, behavioral goals that are achievable, that align with those values, whether they're, sort of spiritual goals that they have for themselves or goals related to their family, that those motivations can then inform specific goals they can measure and set each week. One of the beautiful things about group-based delivery, even though it's not accessible to all people, is that it's an opportunity to connect with others and to, be with people who share their experience and challenges, and to celebrate successes together. And that is a powerful way to improve mental health functioning and, connection. And, I think that ultimately it's fine and potentially helpful for people to work towards that 5% weight loss over the course of 16 weeks to 6 months. But that it's crucial. A crucial ingredient is also nurturing body acceptance through examining beliefs people have about their bodies, whether those are fair to them. Is there another way that they can look at themselves? All the while, we as society need to continue to also work on our biases and change our culture around this as well. Part of the reason that it's really important to set realistic goals and set the stage for this being sort of a chronic and complex journey for people is that many people, even if they do lose weight, face the possibility and likelihood of weight regain. And so preparing people for that setback, preparing people to cope with that, and preparing people to continue to care for themselves and find joy and meaning in pursuing activity and healthy eating, even when that's the case. Because we know that, for example, physical activity in and of itself, regardless of weight loss, is a really crucial thing to promote, and has mortality benefits that perhaps exceed those of weight loss, and certainly has benefits for things like cognition and mental health as well. So, what does behavioral weight management look like among older adults? Well, it's just as important. You might see a lot of the same words on this slide that were on the one before, which is the importance of emphasizing guideline concordant activity and consumption recommendations. One of the biggest problems is extreme diets or extreme low calorie recommendations that can be really harmful to people. And we can imagine that undernutrition or excessive low calorie diets could be really harmful for older adults who might be at greater risk for falls, for example, or lightheadedness as a result of that. And so avoiding those extreme recommendations. Also just keeping an eye on the fact that, many people don't lose weight during behavioral weight management interventions. And if you see excessive weight loss, it could be a sign of a disease process. And so, with or without someone, if someone is not trying to lose weight and you see precipitous weight loss, I'm sure that's a sign to you to get them evaluated. And, even in the context of weight loss intervention, if it's pretty outside the norm, can be concerning. So, and then lastly, in terms of recommendations for older adults to emphasize strength training. Again, something we would do with anyone participating in such an intervention, but it's particularly important and often overlooked in older adults. And then certainly setting people up for success and for injury prevention and, really being mindful about their bodies. But otherwise, the benefits and the approach is really the same. The VA does not prohibit older adults from participating in the MOVE program, and I don't either in my studies, but we just, encourage people to be mindful of their bodies and to talk with their healthcare providers. Here's a handout that we use at the VA. It's a bit busy actually, but I think it emphasizes how you can be active with pain and medical problems along for the ride, relevant to most veterans who participate in our studies, but also certainly older adults. And the idea being that, no activity is really off limits, but it's just about attending to one's body, making sure that their healthcare providers on board with their plan and approaching change gradually and mindfully. Wanted to highlight a few recommended programs that are focused on exercise for older adults that within the VA, there's GeroFit, which is, nationally disseminated across many VA sites. And I'm sure you all are probably aware of it, or many of you are. Also Silver Sneakers is another program in the community. And then NIH, the NIA has some good resources as well that are great for older adults. And we recommend them to veterans participating in our programs as well. So in terms of approaches that are available in primary care, I say here alternatives to behavioral weight management, but they're probably better discussed as augments to behavioral weight management because they all require having or being enrolled in or having participated in behavioral weight management in most settings. So semaglutide is the most effective weight management medication, and it was really recently approved for weight loss by the FDA. Its safety profile is less well understood in older adults, but there's some evidence from diabetes, from folks with type 2 diabetes, that it can be safe in older adults. But that still remains to be understood. And I want to emphasize that this is not my area of research at all. But it's certainly increasing in its, the number of prescriptions are increasing in the VA. I know that much. Metabolic surgery has the strongest weight loss outcomes. It's certainly the most intensive treatment that's available. And so like bariatric surgery, for example, we have both treatments available through the VA or at least paid for by the VA, but they do require, they have a lot of criteria that need to be met, including behavioral treatment engagement. Here's a figure that shows their relative efficacy with the outcome of weight change. And you can see the relative benefit of certain weight management medications. And then you can see that the weight loss is most substantial for metabolic surgery. Bupropion, naltrexone tracks pretty closely to what you see in behavioral approaches, just by way of comparison. We at the VA in our primary care, some of Dr. Scott Hagen, who runs our primary care clinic here in Seattle, has been doing some work in this area to understand the prescription of semaglutide at the VA because of its pretty significant benefits. And we at VA Puget Sound have the highest rate of prescription in the VA at this point. And so I included a few details about what's involved with that medication and also a smattering of the criteria that are, required for receiving this prescription, including, having certain BMI and comorbidities, as well as reviewing for other medications that either haven't been effective or that could be changed prior to prescribing this. It's injectable. So I'm going to switch now to conclude my talk by spending a little time talking about serious mental illness and weight. Now that we've covered sort of the lay of the land of broad behavioral and other, medication and surgical approaches to weight management, my work really focuses on psychiatric conditions and their intersection with weight. And this is a rather busy figure from a chapter that I had the honor of co-writing with Dr. Alex Young. But I want to say that the couple things I want to point out about why psychiatric conditions are particularly important to focus on is that we know that the prevalence of high BMI and related cardiometabolic conditions is higher in people with PTSD and other serious mental illnesses. And as I pointed out before, some of the treatments are less effective for people with serious mental illness. And part of the reason for that, much of this model, though it's not formatted in the same way as the one I've been showing, many of the contributors to weight are the same for people with psychiatric conditions. But a few of the things that I think are really important to point out is that psychiatric symptoms themselves can serve as barriers to behavior change. So for example, someone having, anhedonia is less likely to be able to sort of have that motivation or energy to participate in activity or cooking, that sort of thing. And psychiatric medications also have weight gain potential. And so we have been working towards in our weight management, in my outpatient mental health setting, to do either systemic or individually delivered intervention changes to address those unique barriers to weight management. And I want to highlight in particular the work that I've been doing focused on PTSD. So I already mentioned this, but PTSD in particular is associated with high obesity and related conditions. And the mortality consequences of that are pretty substantial for veterans with PTSD. Move is less effective for veterans with PTSD, as we showed in some of our prior work. And this is due to a number of barriers to activity and healthy eating for people with PTSD. So for example, hypervigilance, being really on alert in one's community for safety concerns, can interfere with being active in one's community. Those PTSD symptoms, especially those that correspond to comorbid depression, can increase risk for binge, emotional, and night eating, which certainly contribute to higher weight and can interfere with changes in weight in a weight management intervention. And then sleep is certainly greatly impaired in PTSD for many people, and sleep is known to be associated with poor eating and physical activity, as well as have a direct physiological effect on weight. And so over the last several years, colleagues and I have developed Move Up, a behavioral weight management program for veterans with PTSD to address those unique barriers for folks. So here's our team. You can see we are a team of many, and pictured here with me is Nadia Suleiman and Lamont Tanksley, who have been working on this with me since the very beginning. And Nadia is the research coordinator for the work, and Lamont Tanksley is a peer support counselor who really co-developed the intervention alongside me, and our funding is listed there as well. So I just want to take a few moments to describe the Move Up intervention, and because I think it's a nice place to conclude about, sort of the possibilities that come from providing behavioral weight management services. So, the reason that we developed Move Up is, as I described, the epidemiological literature showing that there are unique barriers to weight management for folks with PTSD. And I certainly saw that in the veterans that I was working with PTSD at the VA. And we also, though, recognized the potential mental health benefits of behavioral weight management. So, would providing opportunities to work on physical activity and healthy eating in a group setting serve in a way like a psychotherapeutic intervention as well? So we developed Move Up, which corresponds really closely to the general MOVE program in the VA. It's a 16-week program, and it is for people, it includes much of the same content that the standard weight management program in the VA includes. Here we have pictured though Lamont Tanksley, who is a peer support counselor in the VA. So drawing on his own experience as a veteran whose experience challenges himself, he co-leads the group with a psychologist. And that's a common approach to psychotherapy delivery in the VA. So we, as I said, include really standard information about weight management, goal setting and how to pursue goals, optimal dietary recommendations and so forth. But then we also incorporate ways of coping with PTSD symptoms that might be getting in the way of pursuing a healthy lifestyle. So for example, using cognitive behavior therapy throughout the course of the group in order to help veterans evaluate their beliefs that might be getting in their way of being active in their communities, or examining the beliefs they have about their bodies, for example, and body shape and size, and finding more balance and hopefully more peace. So this is the standard weight management handout about the healthy plate, which is recommended by the MOVE program. And so we include that in the Move Up sessions as well, really adhering to those standard recommendations. But we also modified handouts in order to have them be more relevant to folks with PTSD. So this is the standard mindful eating handout, for example, in the MOVE program. And we modified that in order to acknowledge the role of PTSD and how avoidance functions in PTSD, and how mindfulness can help people use a different coping style than avoidance through being mindful. I did want to highlight a handout that we include that may be helpful to people here of websites and resources that have high quality information that veterans are encouraged to seek augmentative resources if they want. And again, recommended sites that are recommended by the US government and have some really helpful tips. I find My Plate in particular a really valuable resource that, whether or not someone is participating in a weight management intervention, can be really, really helpful for helping people guide their dietary choices. The other piece of the intervention is that we include a community walk. And the idea being there that, as I mentioned with PTSD, hypervigilance and avoidance is a real cornerstone of PTSD. And so people avoid going out into their communities, avoid going walking or being, active in their neighborhood, for example. And so, which keeps PTSD symptoms around, and then also, of course, gets in the way of exercising. And so we explicitly include an element in the intervention that involves going for a community walk, and then having people use that as an experiential opportunity to challenge some of their PTSD symptoms and beliefs about being active or out in their community, and also, sort of putting one foot in front of the other and getting some activity and doing that learning together. When we delivered the intervention prior to March 2020, the intervention was held in person in a group. And since March 2020, we've been delivering this program virtually. And so people are doing their community walks on their own in their neighborhood and then coming back together to discuss them, which, has felt like a bit of a loss, but it also the learning is still there in terms of the benefits for challenging PTSD symptoms or PTSD related beliefs. And lastly, the intervention includes some brief counseling calls from the peer support counselor to help people get those individualized support when needed. So in our pilot that we conducted over the course of a couple of years, we had 44 veterans participate with a body mass index of at least 25, people with PTSD, but otherwise the exclusion criteria were really minimal, including that we had veterans who were fairly up in age, many older adults. And so, with that piece, their primary care provider's approval, veterans with mobility limitations, and, a number of chronic health conditions or older age were all eligible to participate. The average age was 58 in the sample, relevant to this group, but certainly quite a range in terms of what those ages were. And you can see mostly, the majority were male, but we still had 30% women veterans, which is, overrepresenting women veterans, and a number of people of color participated in this study. And we had 5 cohorts participate. We modified the intervention over time based on veteran feedback, which I want to share with you all just to highlight how informed the final intervention was by veteran input. They really co-created the intervention. These are the measures that we used to determine, what changes to make to the intervention. So I want to point out, we didn't only focus on weight and whether weight changed after a cohort. We included, we really heavily emphasized things like, their activity and diet, but also their personal input through qualitative interviews about what could be changed. And then in our final intervention package, we found that it was really well-received intervention. And not only did 70% of that final cohort lose at least 5% of their baseline weight, that they also reported really important improvements in physical activity and healthy eating, and things like social support and PTSD symptoms improved really substantially as well. And so, and you can see in the qualitative feedback that we got, I really love particularly this middle quote. It helped me do things that are more relaxing for me to do and get out of my shell and interact with other people that are suffering from PTSD too. So, acknowledging that when people come to us, whether it's for a PTSD weight management group or a general weight management group, that a big side benefit is really, the weight loss may or may not happen, and may or may not be ultimately the focus, but getting that connection with other people and pursuing one's personally meaningful goals is important in and of itself. So we changed the intervention, based on people's input quite a bit from start to finish. And the reason I wanted to highlight this for you all in this particular setting is that, our initial approach with the intervention was really a lighter touch intervention. We had fewer sessions, and it was exclusively peer support counselor delivered. So, much more feasible in many ways for delivery in settings like primary care. And we were not seeing the change in outcomes that we wanted to, whether that was, behavioral outcomes like physical activity or weight, or the qualitative input that we got in interviews was that veterans wanted a more substantial program. And so ultimately we ended up with a program that was really comparable to the MOVE program. And I say this to you all because there's always this tension of, providing a menu of options, and in many cases, wanting to give the lighter touch option to patients, because it's, if you can deliver a high quality intervention in a few short sessions, that's fantastic. But oftentimes we see, over and over again in the literature that with behavioral approaches, a more intensive approach generally produces stronger outcomes. So we, just in conclusion about what we're doing regarding Move Up, this program for veterans with PTSD, is that, we had those really promising outcomes that really outperformed what we see in the general VA, Move program for veterans with PTSD. So we're currently studying that intervention in a R01 level funded trial. And so we'll be testing that, conducting that study until 2024. So we won't have outcomes for quite some time there, but we're having a really positive experience running that trial. And we'll find out whether that intervention helps to reduce those disparities. Just a quick moment to thank the veterans who really co-created that intervention with our study team, because they really gave a lot of really powerful input over time to make the intervention what it ended up being. So in conclusion, as I wrap up this talk and sharing with you all, I hope that the sort of arc of this work has highlighted a few things it has for me that I think are really important to consider when thinking about behavioral weight management. So first is just a reminder that behavioral weight management is can be quite effective, but it also, maintenance can be really tough and very few people participate sufficiently. So we certainly need to help people overcome those barriers if they want to participate in weight management, making sure that they have the technology solutions or the asynchronous solutions that are right for them. I think also helping people see that, and stay engaged if they aren't seeing that, the number on the scale is changing, but helping them understand and approaching the whole intervention in a way that emphasizes the whole health benefits of working on those changes of, physical activity and eating that are emphasized in weight management programs, including mental health benefits. Certainly, PTSD is not the only psychiatric condition that can be improved through weight management approaches. Depression, anxiety have also been demonstrated to have some improvement with working on physical activity and diet. And so, helping people see those other ancillary benefits that are possible for them can keep folks engaged over time. And it's really crucial, and my team is really, really focused on this ourselves, but addressing those disparities in BMI and weight loss outcomes that are observed both within and outside of the VA. We covered those alternatives or augments to behavioral approaches like semaglutide and metabolic surgery. But just like behavioral approaches alone, there are many barriers to accessing those treatments. And so we need to continue as systems to overcome those barriers as well, so that they can really be part of the menu of options available to people. So I come back to, given all those barriers and challenges, that staying, focused on the fact that there are many people who want this care, for a variety of reasons, and making sure that we meet them where they are, whatever their reason for wanting to show up and get care, get support for this. Some things to remember as, as you're considering supporting people around their weight, is to ask permission and interest to weigh people, to discuss their weight, or to discuss recommendations. Because again, not everybody is interested in discussing their weight. And for some people, it might be hurtful. And so there's a growing emphasis on asking permission to do that. As we've talked about this whole time, if someone is interested in recommendations, to emphasize those guideline concordant recommendations that come from NIH, that come from our government, that are, evidence-based, that really emphasize the consumption of, fruits and vegetables, and avoid extreme dietary recommendations, and to help people see their whole health goals and to see where weight fits in with that. And then lastly, just to remember that when we're supporting people with this and encouraging them to be patient and kind with themselves and thinking about where to direct our energies, to remember that body size is just one facet of a really complex system of factors at the systemic level that are driving a number of inequities, including climate change and food insecurity and so forth. And they're all interrelated. And so for us to both encourage people to be patient and kind with themselves as they're doing this work or considering taking on lifestyle changes, but also for us to remember that we have a voice in informing, policy and so forth, so that we can reduce those systemic drivers of inequities. So with that, I thank you, and I look forward to hearing your questions and comments, and do feel free to reach out. My email is listed there.
Thanks so much, Kate. That was just amazing. Really an impressive program that you developed. And in fact, there seems to be, based on questions, some real interest in hearing a bit more about it. So I'll start with that. Lisa says, with weight loss via the Move Up program being less successful with vets with PTSD and or are Black, would the effects of trauma responses in both groups contribute to limbic system dysregulation and increased difficulty losing weight? She says she's a social worker, but she thought that high stress and high adrenal response adversely affected weight loss.
Thank you. Thank you so much for raising that question. And you're absolutely right. And I kind of failed to cover that sufficiently because it's really not my area. And I sort of, yeah, but you're absolutely right. And there's a model that I didn't present that's by Dietert and colleagues that really outlines that I wish I'd included in this talk, because it really shows that multiple levels of influence, and including the stress response and how that directly impacts weight and also influences behaviors like sleep. So, so very excellent point. And I think you speak to the potential limits of our interventions if we don't also address that direct physiological effect on the hormonal system and also all of the myriad biological, I'll call them biological factors. So thank you very, very much for bringing that up. Really important consideration.
Great. And Linda is wondering, what, if any, options are there for participants in the group to continue as a support group to each other after the 16-week program?
That's such a great question. And it reminds me that something I wanted to highlight is that in several instances, both in our pilot and our current trial, that people do end up connecting and then maintaining their own sort of impromptu support group, either like, I mean, not usually the whole group of individuals, but sometimes really pretty meaningful friendships have developed, and people, and of course, those relationships can be really, really meaningful in and of themselves, but can help maintain those gains. So that's one option, or one sort of thing that naturally occurs in the course of the group, much like many group interventions. But then the MOVE program also has a monthly or currently quarterly support group for graduates that brings veterans together who have participated in any time in the MOVE program. And that's available to people who complete MOVE Up as well.
Oh, that's great.
Yeah.
So Beth says pain and other physical impairments are often barriers to walking or other exercise, physical activity. Is physical therapy a part of your team?
Thank you for raising that. Absolutely. Pain is a really significant barrier in our veterans who do our programs. And And so one of the things that I failed to mention about Move Up, and one of the beauties, I think, of delivering an intervention in the context of a really robust healthcare system is that we emphasize care coordination as part of the intervention. So it's delivered as part of routine care. And so referrals are made to things, referrals or connection with primary care, who could make a referral for things like referral to the pain clinic in the VA, or yeah, PT or acupuncture, or sleep hygiene intervention, whatever is sort of needed for the veteran to meet their complex needs.
Oh, great points. And Bill says this was a really good presentation. It made me want to be more purposeful in assessing patients' level of interest about possible weight loss when assessing them for our primary care program. And Lisa said, thank you for your focus on consent and discussing weight or weighing, as well as the focus on patience and kindness and being mindful of our own intersection bias. And Julie said, such a well-balanced, multifaceted lecture. So I don't see any other questions, but a lot of thanks for just the comprehensive focus in this intervention, with much appreciation, Kate, for having an important final lecture for our winter series.
Thank you.
Thank you so much. Everyone, I hope to see most of you in the spring. As you saw, I was trying to post the links into the chat box, so I hope you've been able to access those. And thanks for your attention this entire term, and have a wonderful spring break. Thank you, Dr. Herster.
Thanks so much, everybody. Take care.